It's another great pleasure to introduce the second keynote for today, Jill Ehrenreich May, for our keynote address. Jill is Professor and Associate Chair in the Department of Psychology at University of Miami. She's a world leader in the development and evaluation of transdiagnostic programs for youth. Her work on the unified protocols for transdiagnostic treatments of emotional disorders in children and adolescents is funded by the US National Institutes of Health, and she's incoming president-elect of the Association for Behavioral and Cognitive Therapy. So I'm hoping you'll be able to influence them in a transdiagnostic direction going forward. But without further ado, I'll hand over to Jill for her keynote address. Thank you.
Well, thank you so much for having me. I was just saying earlier that I'm really thrilled and excited to be presenting here amongst some very like-minded individuals with regard to transdiagnostic approaches to treatment. And we've been doing work over the last 15 or so years on one transdiagnostic treatment model that I'll speak about primarily here today on the unified protocols for transdiagnostic treatment of emotional disorders in children and adolescents. And I'm really gratified to see so many friends from Europe and colleagues who've been working on some of our UPC and UPA research also on the line. I do need to just acknowledge moving forward that we have some published books on the UPC and UPA that I make a royalty from. And I always consider myself kind of a clinician first. And so I do a lot of clinical training and sometimes get paid for those trainings, consultation or implementation support. And, the focus of my research, as mentioned, is on the UPC and UPA as well. I don't think I need to tell this group that youth emotional disorders are a problem. We know these are the common cold, if you will, of mental health concerns around the globe, and that during the pandemic, these problems have become, really quite acute. There was a meta-analysis just published in the Journal of the American Medical Association, which seems to suggest that, upwards of a quarter of children have depressive symptoms or have had depressive symptoms during the COVID-19 pandemic. 20% of children have had anxiety concerns that may be of a clinically significant level during the pandemic. So, we really are having a crisis with regard to these problems. It's particularly important to think about these concerns in youth. This is the time frame in which most of these problems have their genesis in middle childhood to early adolescence. We know that these are chronically impairing across multiple domains for youth. And, particularly when we're talking about something like anxiety, there's a high degree of stability in certain clusters of these symptoms, in particular, things like worry that can be stable across time and be sort of not quite as easily amenable to intervention. We have concerned ourselves in the field for the last, 35 or so years with constructing evidence-based approaches, mostly cognitive behavioral approaches to these concerns that largely have hewed to a sort of a nomothetic understanding of diagnosis using kind of an ICD or DSM framework. And what that has resulted in largely is a number of amazing manuals. And whenever I do these talks, I like to just start off by saying, these are all great manuals. You should buy, you should buy every single one of these. I even wrote one of these manuals, co-wrote one of these on panic disorder, for CBT for panic disorder in adolescents. So there's nothing wrong with these treatments. They all have evidence bases behind them. They all work for single disorders or single problem areas. But you can imagine that if you are an organization that wishes to adopt evidence-based treatments or cognitive behavioral treatments into the framework of what you do, or you're an individual clinician who is approaching these problems for the first time, you may be very confused about which of these approaches to pick up or which of these manuals to pick up for an individual child client, because the reality of the use that we see in clinical practice is that they do not come in neat little problem or disorder specific packages. And there is concern, although it's possible possible that concern is unfounded, that some of these individual manuals may not have sufficient flexibility to treat sort of the heterogeneous youth that we see in routine clinical practice. So once again, I don't think I need to tell this audience that multi-problem youth are the norm, and that the majority of children who come in for clinical services have at least one comorbid diagnosis. As developmentalists, we don't just want to think about comorbidity at one time. We also might want to think about it as developmental sequential comorbidity. We know that we have a child who comes in with separation anxiety, that child may be likely to present later with generalized anxiety or with OCD, or depression at a later time point. So we have to think about prevention in our intervention models for youth as well. And that is true both within class of problems and between problem types. So, certainly that would suggest that a problem-specific EBT might not be the most useful framework for treating most children in clinical settings. And of course, add to that these sort of, if you might think of them, kind of transdiagnostic stressors during the pandemic that have worsened a range of problem-specific clusters at the same time. Things like social isolation may have impact on a multitude of anxiety or depression or irritability related constructs, for example. So, certainly if we're just looking at anxiety and depression symptoms, we can say that these concerns share genetic, neurobiological, and other environmental risk factors. At a symptom level, as you can see here from a network analysis that we recently did with 467 clinical youth who have received UPC or UPA over time. These networks seem to show that depression and anxiety are highly related and intercorrelated. Interestingly, regardless of the informant, although the structure of the network is a little bit different between the two informants. And of course, symptom to symptom relationships are stronger within sort of cluster as opposed to between. But this sort of, again, gives us some greater evidence that sort of approaching these things transdiagnostically might in fact sort of capture a broader network of effects than we're anticipating. And, from a pragmatic perspective, evidence-based treatment approaches, particularly our cognitive behavioral approaches to these disorders, also share techniques across problems, across disorders, with subtle but perhaps important differences in treatment principles that are applied. So for example, within opposite action strategies, we might use behavioral activation techniques more with some youth who have more irritability, more depression, and more exposure-based techniques with children who are showing more fearfulness or anxiety. And in fact, when you look inside all of these great manuals that already exist for effective treatment of these concerns, you actually kind of find a lot of the same things, albeit pitched in disorder-specific or problem-specific kinds of ways. So largely, you see things like a focus on emotion identification or increasing the degree to which one is labeling affect, something that we know is important for exposure as well. Some education about how emotions impact our behavior, particularly leading to problematic or maladaptive patterns of things like avoidance, escape, aggression, compulsions. And given that most of these are CBT manuals, you're going to see a focus on some level of cognitive intervention, albeit traditional Beckian cognitive therapy, or more mindful awareness in more modern or updated manuals. And a range, once again, of opposite action strategies. I would say one area in which these sometimes differ a little bit more between manuals is in how much of a caregiver focus there is, and whether that caregiver focus is just sort of sharing material about the youth intervention itself, or whether there is a mechanism associated with change related to the caregiver, for example, adjusting, say, accommodation behaviors relative to the child's distress in order to lessen sort of child emotional disorder symptoms. So, a number of us have approached this sort of co-occurrence of problems within the emotional disorder spectrum in a couple of different ways. Lauren Marchette and John Weiss in 2017 published a paper in which they attempted to sort of categorize some different transdiagnostic or multi-diagnostic approaches to use treatment. And they categorized them as either common elements approaches, so where there are parcels, if you will, of evidence-based treatment techniques that are sort of designated for broader spectrum problem areas like anxiety writ broad or depression writ broad, and algorithms for how you could move back and forth between these different common elements of treatment. Principle-based interventions, this is similar to John Weiss's first manual, where there is attendance to sort of some of the common elements and a kind of a broader range of higher order factors across disorders. And then in that paper, they talk about the unified protocols as being a core dysfunction focused approach, meaning that it's purported to treat one sort of higher order factor that might cut across emotional disorders. I think it's a little reductionistic, but I do sort of understand sort of the different categorizations here. But if I kind of look at my own manuals, these are the UPCs and UPAs manuals. I mean, I think that we could say fairly that we are purporting in our theory to treat a core dysfunction or a higher order factor, which I'll talk about more in a second. But it also has, these common elements of, core interventions that I just showed you a moment ago. They also have a modular structure and a flexible administration of materials whereby you can sort of move materials around or sort of personalize it for different types of emotion focused kinds of concerns, or a blend between these kinds of concerns over time. I mean, one could argue this is also like kind of a soft nomothetic way of looking at things too. We're still focusing on, sort of an emotion that is associated with particular disorders rather than using the disorder specific language. And I think that's a fair criticism of this approach as well. So, we have termed this sort of higher order factor as neuroticism. And we believe that it can be engaged in treatment across youth with differing emotional disorders. As mentioned, this might be particularly relevant for youth populations because developmentally we expect shifts in the specific type of disorder we see over time. From a conceptual point of view, neuroticism here refers to children who have heightened negative affectivity in response to a particular trigger or stimuli, and have difficulty tolerating the uncomfortable sensations in their body, and cognitively difficulty tolerating that distress. And you can imagine that if you are having difficulty sort of managing, very intense feelings in your body, and you're having what you feel is a strong affective response to a particular trigger, you're going to want to get away from it. I mean, that just makes sense, right? So we are going to engage in we're going to engage in some short-term strategies that we could sort of term under the kind of larger umbrella of experiential avoidance, but really could be a range of behavioral avoidance strategies: escape, compulsions, aggression, suppression kinds of behaviors, cognitively in order to manage this situation. And these are somewhat self-reinforcing over time. Interestingly, if we think about it from the caregiver perspective, as parents, we may also see our children having these heightened reactions to emotions and have strong emotional reactions in our own bodies when we see them upset, and that may lead to other unhelpful behaviors in this situation. So whether that's criticism or accommodation, or inconsistent reinforcement and discipline strategies that may also reinforce this pattern of neuroticism over time. Our research on youth with emotional disorders has suggested that these purported aspects of neuroticism do in fact form a latent construct, that latent construct of neuroticism is associated with parent and child ratings of symptom clusters across anxiety, depression, OCS, and global severity kinds of measures. Although interestingly, our attempts thus far at looking at sort of process-based change or mechanistic change in some of these factors has been less exciting exciting, so to speak. And we see sometimes changes, not necessarily in these things in association with, say, the module that we expected was going to modify them, but just overall and somewhat conflated at times with anxiety and depression symptom change as well. So somewhat unhelpfully, we have two versions of this manual. One that is targeted toward adults, and this was developed when I was at Boston University with Dr. Barlow as part of a career development award. Did a lot of crosstalk over time between the UPA and the adult UP in the second iteration. So they are more similar now than they were really even at the starting point. But again, this is a modular, individualized therapy. It can be and is done in groups at times as well. It is meant to be time limited in its, and I think in reality, you can easily get through all of the modules in 16 or less sessions, and many people have done it quite a bit more briefly. There are 8 core modules, which I'll show you in a minute, and some caregiver focused materials in a module as well. And again, meaning that it's modular, you can do these things in any order. There's probably a logical start point and a logical end point, but in between, you can really vary up the order quite a bit. While we were doing the randomized control trial on the UPA, the first waitlist control trial on it, we started developing the UPC as well. And the UPC is a 15-session emotion-focused group treatment. It's very similar in structure to the UPA, but it is very activity-focused. Colloquially in-house, we tend to refer to it as motion detectives. It's got this sort of central metaphor of, becoming a detective to solve the mystery of your strong emotions. And you use the clues skills. We have an acronym like any good CBT treatment does to help solve this mystery. Because it's very activity-focused, because it's got sort of a lot of games and things like that, I think children under 13 are largely the sort of target population for this. So, probably between the ages of 6 and 12 or a younger 13-year-old would be able to do it. We also use this as an individualized modular treatment, so it does not need to be done in group. When we look inside the content of both UPC and UPA, and I'm just kind of lining up the modules here, not because you have to do them in this specific order, but just to show you the consistency between the two approaches, even though there is a lot of developmental difference in the way the materials are pitched, the degree of reinforcement, the degree of activity between the two. The content is largely the same, and it all starts really with idiographic assessment. So in the beginning of this treatment, we do a top problems assessment. We do case conceptualization work within the neuroticism model. We are also doing things like functional assessment throughout the treatment using what we call the ARC model in the adult UP, antecedent response consequence, or the before, during, and after form in the child versions. So there are many opportunities built in to personalize the material. We are somewhat flexible in how you use these materials. So I think that's something that, is a target for future directions, but they're there. And, interestingly, within sort of the other modules, we're going to see a high correspondence to those core elements of evidence-based treatment, but again, pitched across emotion. So emotion education, a focus on opposite action and behavior change, really from very early on. Like, we do some motivational enhancement work in the first module where we are setting goals for children to start working on little steps and building self-efficacy that they can sort of engage in new or different behaviors from the very beginning. There's body awareness strategies, present moment awareness strategies, things like interoceptive exposure, narrative exposure strategies. The idea here is to take what is in here and, of course, not use every single bit of it, but to really sort of think about, are these sort of necessary and helpful skills for this particular child? So, for example, within our cognitive module, we have some traditional, what you might think of as antecedent cognitive reappraisal materials, where particularly before a child enters a difficult situation where they might sort of identify thinking traps and walk through some reappraisal or restructuring steps. But for other children, it may be more useful to focus on problem solving, or when they're sort of, after they are kind of dealing with a difficult situation, how can they be flexible to come up with solutions? There is a theme really throughout these manuals of emotion exposure, exposing yourself to the emotions that are sort of leading to this pattern of maladaptive behavior and moving toward what we call a more helpful versus less helpful pattern of behavior over time. As mentioned, we have an entire caregiver directed component to the UPC and the UPA. It's much more extensive in UPC. 10 of the 15 sessions in the group version have a parent group component, so to speak. And in that caregiver component, we are on the one hand having individuals focus on functional assessment and really thinking about it in the context of when they observe their child's emotion, what kind of response are they having in their bodies to those triggers when they're seeing their child having strong emotional expression or maladaptive behaviors. What kind of does that bring up for them? And we'll walk through a functional assessment for them of what they do, and are they falling into what we might think of as emotional caregiving behaviors here, where they are again reinforcing these patterns of neuroticism over time, again somewhat accidentally. Nobody really kind of steps into it saying, I would like to make my child's symptoms worse, if at all possible. And then we are working with them in a more personalized way, or in the group in a more structured way, in doing what we think of as opposite caregiving behaviors to counter these over time. So like I mentioned, we've been doing research for about 15 years on the UPC and UPA. And I feel like we've kind of come to some understandings of where we are with this approach. And I'll try to walk you through a couple of lessons that I've learned from the work. I mean, first and foremost, you know, it works. I think that we can say with some level of, you know, trepidation, but still, at least in research clinic samples, this seems to be a program that has some efficacy. As mentioned, we did an initial randomized control trial compared to waitlist for the UPA when we were first developing the manual up at Boston University and then at the University of Miami. This was a relatively small trial of 51 adolescents who were randomized to receive either an 8-week waitlist or 16 weeks of the UPA. And what we found was that at the end of 8 weeks, at the end of the waitlist sort of time period, the UPA was outperforming the waitlist in terms of clinician rated measures, but not as much on the RCADS. Here, when we looked all the way out with everyone out to 6-month follow-up, we do see significant effects across all of the measures, with the exception of the RCADS adolescent report on, you know, again, on most indices and in terms of life interference, and the effect sizes were large. And again, that's, you know, obviously what you hope from a waitlist control trial, that it's better than nothing. And so we seem to have seen that initially. Around the same time, we did a smaller randomized controlled trial in-house comparing the UPC to an existent cognitive behavioral group treatment for anxiety. That's the Cool Kids manual. It's Ron Rapay's group manual for child CBT. This was really a small trial, and honestly, we probably could have collected like 500 children and maybe not seen a big difference between conditions over time. And you know, we've seen this also in the adult UP literature with a larger. So I got muted somehow. Okay, I don't know if people heard the last thing I said, but in essence, that we in fact did not see differences in anxiety symptoms between the two groups. But this trial was really interesting when we looked out at the follow-up points, at the 3-month follow-up. What we ended up seeing was that many of the children who were in the UPC group were still responders. So 94% of the children at the follow-up continued to no longer meet criteria for their primary concern, whereas only 54% of those in the Cool Kids condition. You know, again, take it with a grain of salt. This was a small trial, but the other significant effects that we did see were interesting as well, showing sort of broader based impacts of the intervention potentially on things like sadness dysregulation and reappraisal on the ERQ-CA. So the ethos of my lab is that basically we're always collecting data. Whether we're randomizing people to a study or whether we're just collecting information on a within subjects sort of administration of the UPC and UPA, everybody in my who comes to our treatment program gets the UPC or UPA. So we're able to look sometimes within subjects at other clusters and kind of understand how the intervention may be affecting other clusters that maybe aren't as common as the primary disorder, but are common as subclinical or additional disorders for the group. And this is an example of that, a recent study that was published by Ashley Shaw and colleagues, where we're seeing significant parent and self-report improvements in the ARCADS OCD scale for those who received both intent to treat and completers who received the UPA and UPC. We've also been looking at parent response and seeing a very uniform improvement on the DASS across sort of anxiety, depression, and stress scales in response to the UPC. Interestingly, we have continually found these reappraisal effects. I always think of myself as like a staunch behaviorist. So I'm always like, what are we doing that we're getting such effects on reappraisal? But you know, the distress tolerance findings here might be particularly important. They are also associated. Parent distress tolerance change also was associated with youth symptom improvement, again, by parent report. And you know, these are things that we need to increase the density of assessment on to sort of really unpack a little bit more in terms of what kinds of emotion regulation behaviors amongst caregivers are associated specifically with youth treatment improvement. In addition to that, we've looked more at things like predictors and latent profiles of response as it relates to the UP models. And what we saw when we looked at UPC largely is very few predictors of response. So meaning that, you know, this is probably a fairly robust intervention. Even some of the typical predictors that we see in other CBT studies related to age or gender are not sort of showing up for us. But what we are seeing is some lesser response for those with elevated social anxiety. I tell you, this finding kind of like haunts me at night. Because I always am thinking like, what can we be doing to engage our kids with social anxiety more in the intervention? I think these are harder kids to engage, you know, and I think that we, you know, also have thought about it as, are we, you know, in terms of like, are we missing something related to positive affect engagement that we need to be doing a little bit more of? That, you know, we know these kids with social anxiety are at such high risk for depression, and that maybe we need to be thinking a little bit more broadly and less just about negative affect change and also about positive affect change. But again, you know, in general, these are all very positive findings in terms of response. This is a paper that we've just revised and resubmitted again. So I'm hoping that it is the last time we're doing that. You know, this is a sample of 290 youth in which we identified 3 latent profile patterns across emotion regulation indices. And for the most part, we see, as expected, that a moderately distressed, dysregulated profile is generally doing the best as it relates to the UP, or is doing relatively well. But, you know, interestingly, there is this 10% of youth that are characterized by low distress tolerance, high anxiety sensitivity, high negative affect, and poor regulation that have the most severe symptoms. They have the worst outcomes. And of course, this might be true really for any intervention. And it's not that they were non-responders, they just didn't respond as strongly to the intervention. I mean, to me, this in particular makes the case for personalization more than anything. You know, some of these, some of these profiles, you know, may benefit from briefer treatment, which I'll talk about in a second. You know, some may suggest that they're fine with standard treatment, and others, you know, are indicating to us that they might need more either intensive forms of the therapy, or they may need a therapy that can be provided on a more intense basis. And, you know, again, I think this is also supportive of the treatment model, because it suggests that more severe levels of some of the UP transdiagnostic constructs are associated with particularly poor outcomes, which again is what the model would predict. So, as mentioned, we're collecting data on everyone that comes into our program and is receiving the UPC and UPA. And we've been thinking a lot about that we need to make better use of some of our idiographic tools. And so we are applying some machine learning methods, say, for example, to our top problems data to try to understand if certain content areas that were identified with machine learning methods are associated with certain profiles of change. A former graduate student of mine, Jamie Sherman, again, identified that our current assessment methodologies are again, just showing consistent changes between these emotion regulation patterns and symptom patterns. So, in order to really, get a better sense of indicators of change in neuroticism, that would signal the need to increase or decrease the intensity of some of the skills or switch to another module, might require other modes of assessment. So we've been starting to use ecological momentary assessment to try to get more frequent and different types of indicators of such. So, generally speaking, we can say the treatment works, it affects psychopathology indicators, there's indications that it affects certain emotion regulation indicators as well. There are a few predictors of poorer outcome, but the question that really is begged by that latent profile paper is, could we do it briefer for some people? Could we give them, some of these transdiagnostic elements in a more abbreviated package? So largely in collaboration with Eric Storch at Baylor University, we've been doing a series of projects related to step care and brief care using the UPC and UPA. This first chart here comes from a study that we did collaboratively for individuals who were affected by Hurricane Harvey, which is which was a hurricane that hit in Texas and caused a lot of flooding in the Houston area. So a lot of people had to relocate or lost their homes. And so anybody who was impacted by Hurricane Harvey and had elevated anxiety or depression was eligible for this program and was provided a stepped care model whereby they got 6 sessions of the UPC or UPA or adult UP. And then we did sort of an assessment to see whether they needed an additional 6. And interestingly, particularly with regard to the UPC, and some of these findings, I forgot to put the citation on here, are published in Cognitive and Behavioral Practice by Sarah Kennedy and colleagues in 2021. A good proportion of them did not step up from the first step to the second. So we were seeing a real kind of meeting the need of a lot of these kids with the 6 sessions alone. Now, there are 2 features of this, I think, that are really important to that effect. One, this was heavily caregiver directed. There is child-directed material here, but most of the session was with the caregiver or with the caregiver and a child together, and the caregiver was tasked to kind of teach the child to do the strategies. I think this was a real element here that was highly important. There was investment from the caregivers. This was all via telehealth, I should say. And there was also very early and consistent engagement in opposite action strategies. And I think that when we come to a larger effectiveness trial that did not show as robust effects of the UPA, I think we could say with some assurance that the reason that might not have been happening in that trial was because of the lack of sort of consistent provision of exposure strategies and other behavioral strategies early and often. So this has become sort of my mantra, particularly with the brief research that we've been doing. We also collected, just on that first 6 session parcel of sessions, data with 129 children during COVID. So this was only to the caregivers, so there was no child involved in the session. And what we saw is sort of medium effects, generally speaking, across domains, so across depression, anger, stress, The COV-TABS variable that showed the larger effects is a COVID-related stress variable and anxiety as well. Now, why were we seeing positive effects here with just the 6 sessions? Well, when you look at the satisfaction data, I think it tells a story. What the parents and caregivers were saying was that they felt that they learned how to help their child manage their distress, how to help them to express their emotions and handle them more effectively. If you note in this sort of satisfaction data, you know, almost all the parents were saying that they would have liked more sessions. So, you know, only 37% said that they were happy with just the 6 sessions alone, but they were showing moderate effects even at the 6 sessions. So again, there are probably some parents in there, like we were seeing with the LPA findings, that probably needed more. And if we can do a better job of identifying who those are at the outset, right, we can triage people to sort of different levels of this intervention. I'm not going to show any data from it because we're still wrapping up the paper, but we also ran a randomized controlled trial during COVID at Miami, where we were actually just treating the parents with a preventative intervention program for themselves. So this had adult UP components, and it had also parts that were focused more on parenting effects. What was interesting is this was a waitlist controlled trial as opposed to what I just showed you, which was an open trial. And what's interesting when you start to measure caregivers during this time is that, you know, there was a lot of natural recovery amongst the caregivers over the longer period of time during the pandemic. You know, this was all data collected here in Florida that kind of opened up early. I don't know how much you know about Florida, but it's like a little crazy. And, you know, apparently COVID doesn't exist here, and, you know, we could all go back to doing our normal things. And so, you know, where we started with the, I'm joking, of course, and where we started, you know, with regard to the caregivers to where they ended up at the end of the program was also really affected by the fact that kids were able to go back to school, you know, and do some things. So we did see some natural recovery, not as much of a, everybody did get better in terms of symptoms, but not necessarily differentially between groups. But what we did see once again were effects on distress tolerance, you know, more so for the parents who did the UP caregiver condition, some increased parenting self-efficacy as well. And we continue to collect data on this in a services grant that we have. So really exciting. Just a couple of weeks ago, we got funded by National Institutes of Health here in the US for an industry partnered project. This is a collaboration between myself and Dr. Jessica Schleider from Stony Brook University, who's really been pioneering research on youth single session interventions. We'll be working with 3C Institute to try to develop single session adolescent directed modules of the UP that can be direct marketed to adolescents, but also could be utilized in a platform in various locations like schools or pediatrics practices, and where the youth will select which module they want to use rather than the clinician or someone else selecting for them the order of these materials. So we're excited about that. A few other things that I just want to show you. You know, there have been many people who have done adaptations and modifications of this approach. In fact, so much so that we just recently published a book on applications of the UPC and UPA from Oxford University Press. I want to point out that, of course, all of our trials have included youth with anxiety, depression, OCD, and other related concerns, as always. So most of these applications either related to a different setting, so intensity related to an IOP program or residential program, lower intensity interventions in pediatric settings or schools. What's interesting about some of these adaptations is that to a certain degree, they often will involve lay health workers or others, you know, learning to be behavioral coaches or exposure coaches for use of the strategies across different situations throughout the day. And then there's been a host of problem-specific applications of the work. This is just one of the laundry lists of ways in which the materials have been adapted. Many times, I think it's really important to step back and say, what are we treating in these cases, like when we're applying the UPC and UPA for early onset serious mental illness, for example? We're still treating neuroticism, right? We're still treating the emotion regulation variables that we're targeting here, but in co-occurrence with other problems, right? Or as part of the realization of other problems. There have also been some other kind of more mechanistically focused adaptations of the intervention. I think one that's really interesting is for irritability. This is work by Jessica Hawks and Sarah Kennedy at the University of Colorado School of Medicine, where we are sort of, doing a more significant adaptation, both in terms of length. This is 10 sessions typically, and focus of the materials around a particularly important area of distress around irritability, because we know these kids have similar types of responding to other kids who have emotional disorders, in the sense that you can sort of walk through our case formulation model and apply it as it relates to irritability, that these kids have trouble regulating the distress that they have when they're triggered, and very heightened negative affect. But the behavioral response, right, is different. It is, kind of more of an aggressive response that you could argue is experientially avoidant, and certainly reinforces the cycle in which you kind of end up using these types of emotional behaviors again and again. But it looks a little bit different conceptually. And in reality, with the implementation of this approach, we are focusing on a different type of exposure here, mostly exposures to irritability, to frustration. And once again, I think that this type of an adaptation is successful because there is heavy caregiver involvement in this one. We are really teaching and coaching the parents to manage irritability in vivo with the child using the UPC strategies. There are some other interesting adaptations of the material here as well. So those of you who might know UPC know we have these thinking trap characters, these little cartoon characters who have cognitive distortions, and we add one here, Out to Get Me Owen, that is focused on hostile attribution bias, for example. So finally, just want to sort of mention some of our less exciting outcomes as well, and to be humble about those too. Some of the prevention trials that have been done in Europe, for example, on a universal basis have not been very successful as it's related to the UPA. There was an implementation of a universal prevention in schools in Spain, for example, where they got sort of like a didactic presentation about the UPA, or they just were doing their homework during a free period. And there wasn't much difference between the two conditions on the universal basis. But if we looked at sort of selective or kind of indicated prevention, those with heightened anxiety and depression did do better in the UPA condition versus the control condition. But again, I think we've seen also in our own research that it probably does work better as a selective or indicated prevention and not as a universal prevention in particular. We also did a large-scale multi-site effectiveness trial funded by the NIH here in the United States. We're just wrapping up analyses from this, so I'll give you kind of a hint at where it's going. And obviously it's in this section of the talk, so you can sort of guess it didn't go so well. But in essence, what we did was randomize adolescents and therapists at 16 community mental health clinics that here in the US is clinics that typically accept public aid as sort of the means of payment. So these tend to be lower resource children by and large. And they were randomized both within agency for therapists and adolescents to treatment as usual at the clinic, treatment as usual plus a measurement and feedback system, or the UPA plus measurement and feedback. So it was a lot for some of these clinicians to learn. And that is part of the story. Generally speaking, we recruited 193 adolescents. These were racially and culturally diverse youth from Miami and Hartford, Connecticut. They had multiple life stressors, but none of these demographic or other factors seem to be impacting outcome. There's some interesting stuff that I won't have time to go into here about that. Some of the services were office-based, some were home-based. The biggest issue we had in this trial was that there was very high staff turnover. The modal number of clients that any individual therapist saw in this trial was one. So that's how bad the staff turnover was at these agencies. We just could not retain people, once they were trained. Either they left the agency or the good ones got promoted within agency and then couldn't keep seeing anyone in the trial. So there are some findings that suggest the UPA outperformed TAU. In particular, there's no differences between the MFS condition and UPA condition. Some of those are complicated by site differences, which, going back to when I talked about this for cool kids, or how we've seen with the adult UP, there does not seem to be differential outcomes when compared to disorder specific approaches, and you don't expect there to be. So in one of our sites that provided the largest number of children to this trial, their TAU was largely TFCBT. So you're not going to expect that it's going to outperform TFCBT. So at the site where that was not the case, the UPA outperformed TAU, but not at our local Miami site. So I just, as I wrap up here, want to just put in a pitch for some of the personalization work that we are finding to be incredibly important moving forward. I never personally want to do an effectiveness trial again, where we are not using mixed methods in our means of implementing this treatment. We had a lot to learn from those community mental health agencies, and just prescribing the intervention at the outset and hoping that they did it without supervision in their agencies was a bit foolish. And I think, moving forward, this is our development plan for a school-based implementation of the UPA that will use extensive stakeholder feedback in order to implement. This is going to be a telehealth-based school intervention before we enter the randomized controlled trial phase, and even during and after. So in just closing, I think that we can say that the UPC and UPA do work. Transdiagnostic treatments definitely work with children, but we need to do a better job moving forward of understanding how to help people personalize, and importantly, to do so in a way that clinicians can learn and can implement themselves, right? So that we saw in that effectiveness trial that I showed you in COMET, that very few of our clinicians used exposure therapy. And that was despite training from me, despite consultation. And so we really need to think about what are the real barriers to using what we think are some of the most effective strategies here, and build that into these more personalized plans. I'm fond of saying that I like the neuroticism theory, but the theory is just the map. Right? It's not the road, it's not the sky, it's not the destination, right? And that context matters always. And so in implementing this, really understanding the importance of the youth context, the caregiver context, and the treatment context is key. And finally, we're really excited about the directions related to brief and strategic applications of the UPC and UPA. We just need to make sure we know which children and which families are going to respond to them the best. So finally, this is my team from the University of Miami. Every clinical trial, every effort at doing anything related to the UPC and UPA is thanks to these people and these wonderful dedicated students, postdocs, staff members, and those, of course, who I've worked with in the past on this approach as well. So thank you very much for your time.
Thank you very much, Jill. Can you unmute yourself, everybody, and give Jill a round of applause?
Thank you.
Thank you very, very much.
Yeah, thank you for such a comprehensive, detailed, and so much decades of hard work that has gone into all those analyses, but also kind of, sharing your kind of modesty around how it translates into the tough context that some of these youth are in. We've got time for a question, which could either go in the chat, or if someone wants to raise their hand, and then we can go into our break after that. I know Tim was listening intently, so I don't know whether he's got a question, but if anyone else has, do raise your hand. I think it comes up to the top of the screen if you select that reaction. Otherwise, you could. Oh yeah, Tim has got a question.
I think Tim has a question. Yeah.
Go on, Tim.
I was just going to ask you. Well, firstly, thanks for this great talk. The idea of it becoming more personalized, does that mean you're going to be converted to the kind of modular approach?
Well, I mean, inherently, the structure is modular. We just, I think that people read it as non-modular. And I think that's our fault in how we wrote it. And so one of the things that, we have been feeling very strongly is that people need better supports for how to kind of use the modular structure more effectively. And again, how to use it more briefly, that, you don't have to go through every module. You don't have to put exposure last just because it's in module 7, right? Like that's in fact antithetical to what we really want people to do. So yeah, I'm converted.
Thank you, Jill. That's super. One more brief question for Jill before we go to a break. Anybody? Welcome to raise your hand as a reaction or use the chat function. Okay, I think therefore we can go to our break. We've got half an hour where you can either get something to eat, have a chat in this forum, maybe with Jill, maybe with each other. And then we've got 3 more talks after this break. Thank you again, Jill, for such a comprehensive and illuminating set of studies. Thank you.
Thanks for having me.
Okay.
I thought that was really nice, Jill. Thank you.
Yeah, very informative. Thank you so much, Jill.
Oh, my pleasure. I'm excited to have presented it here.
You want to stop the recording, Warren?
Oh yes, let me do that.